Okay, great. We are back. Hopefully you're ready to dive into what I consider to be one of the more important parts of this talk. Remember I said that we would talk about sort of the layers of stigma? So I want to weave together all of the things that we've just talked about and sort of give you a conceptual framework for this. It's not going to include some of what we chatted about, but it should be sort of one of your big takeaways. One of your big takeaways should be the types of stigma that exist. And so let's just start at the bottom here. We're going to start with structural stigma, but don't worry, we'll come back to interpersonal stigma and self-stigma because these three things are very, very intertwined and they all exist and coexist because of each other. So first, I want us to hang out at structural stigma. Let's start there. We talked about this briefly, but I want you guys to first just tell me, think about it for a second, and then feel free to put it in the chat. What is structural stigma? Yeah, someone said institutional norms, whether or not they're accurate. I love that. Institutional norms, whether or not they're accurate. Michelle says stigma associated with ideologies. Absolutely. I'll wait for a couple more to come in, but you guys are nailing it. It's the moment when things become embedded in our cultural norms. And when they're embedded in our cultural norms, they shift to influencing our institutions, our laws, our policy. They shift where our funding goes. So we have structural stigma based on cultural norm that people with substance use disorders are bad, that they need more accountability in order to get better. We have structural stigma based on these cultural narratives that people can't recover, that they are selfish, that criminality and substance use disorders are often intertwined. Okay, Nikki said something really meaningful, which I'll come back to in a second. So when we're talking structural stigma, we're talking really, really big. Structural is, again, where things become cultural norms and then end up being represented in laws, systems, institutions, policies. So the policy at the emergency room at a big hospital, what's the policy post opioid overdose versus the policy for tending to someone with a myocardial infarction? It's when our cultural norms get translated into large systems. And I want you guys to tell me in the chat, give me an example of a policy or a law or organizational culture or something institutionalized that is stigmatizing and impacts people who use substances. Just one example of something that is structural and impacts the care of people who use substances or the lives of people who use substances. Criminalization, yeah, absolutely. Criminalization, probably like the easiest and first up when it comes to structural stigma. We have criminalized substances. We could sort of have a healthcare response to substances. Some countries actually prescribe substances, right? Like if you go to Canada, someone has an opioid use disorder, we just prescribe agonist therapies like heroin or fentanyl. Keeps people safe, keeps people out of the criminal justice system, and for the most part keeps people pretty healthy. But we, in the setting of stigma, and absolutely it's about structures, we have chosen a criminalization pathway here in the US, absolutely. Ooh, yeah, someone said disparate payment rates or benefit coverage, absolutely. You know, I don't know if this is still the case, but there was a time period where I would get reimbursed differently for an office visit in which I coded a psychiatric illness versus a substance use disorder. So there was actually a time period where if I was, depending on the setting I was in, I would code my chief complaint under, let's say, PTSD, and I would code my secondary complaint opioid use disorder because I actually got paid more for treating PTSD. Same office visit, same amount of time, but the billing code for PTSD was higher. The billing reimbursement, I should say, was higher for PTSD. I think that's probably shifted at this point, but there was a time where literally the value based on treating someone's psychiatric concerns was greater than treating a substance use concern, which is bonkers to me because in my mind, they're all just in the DSM and it's all one organ. It's all one organ. And so that we would reimburse differently based on the way that the symptoms present makes no sense, but it shows you where our values lie. So that's structural. That's such a good example of structural. Someone said people on parole being required to do a UDS resulting in reincarceration. Yep. No leaving hospital or emergency room to smoke tobacco. Yeah, I do think that that is likely a good, that's about policy, right? That's about policies, absolutely. Great, these are good ones. Structural sometimes is really, really hard for us to wrap our brains around. So keep trying to think of examples of structural stigma because it's probably one of the biggest that inhibits health and wellness for people that use substances. But because it's so big, it's often invisible. It often is just something that you and I are not seeing on a daily basis. It has to do with the policies that the state is writing. It has to do with the laws that are being passed. And you and I might not be seeing that stuff intimately on a day-to-day basis, but we might be seeing interpersonal stigma. And so I want you guys to pivot just for a second. And before you think of examples, I want you to tell me what interpersonal stigma is. Tyler says medical treatment, sometimes housing or other services, having strict requirements for sobriety and 100% adherence to a treatment plan. Yeah, absolutely. Saying, hey, if you're using substances, then we can't do this. Which sometimes, I will say in defense of some surgeons, sometimes substance use actually is like prohibitory for healing from recovery, or sorry, healing from surgery. And sometimes this stuff is just about structural stigma, absolutely. Patients with substance use history not always being able to access SNFs because of that history, absolutely, that's a great structural stigma. Structural stigma example, lack of substance use disorder care in jails, absolutely, that's structural stigma. So this person said rehabs not admitting people who are actively using substances or intoxicated, yep. And I want you guys to pivot over now to what's interpersonal stigma. It's embedded in and born of structural stigma, but slightly different. What's interpersonal stigma? So interpersonal stigma is the stigma that shows up. Okay, there we go. Sabrina, interactions between people, often people important in each other's lives. Yeah, absolutely. Rachel says family, friends, coworkers, others. So yes, interpersonal stigma is the stigma that shows up in relationship. Interpersonal stigma is the stigma that shows up when a person using substances shows up at primary care and their primary care provider treats them differently because they know they're using substances. Interpersonal stigma is the stigma that shows up when a nurse tends to a patient that has wounds that are related to substance use and potentially is more abrupt or spends less time with the patient or tends to their pain less as they're tending to those wounds. Interpersonal stigma is when a mother treats a child differently or a child treats a mother differently because there's substance use involved. Interpersonal stigma is when there's a relationship or an interaction between two people and stigma shows up and influences it. And this is the one that we hear our patients and our clients talking about so regularly. Here's how I was treated when I went to the emergency room, or here's what my mother said to me. This is the one that shows up and is so easy for us to see. Unlike structural, it's not big and invisible. It's often right there in front of us. It's right there in front of us because those relationships are all about, those relationships are where our nervous system can feel safer, and also where our nervous system can feel less safe. So it's like right there. And when there's stigma, the nervous system is going to feel less safe. You can feel it right away. So what are some examples of interpersonal stigma that you know of? This one should be easier than the structural stigma piece. Again, structural stigma is often so hard for us to locate because it's so big and so invisible. But interpersonal stigma, we likely hear about it regularly. P.S. That's Shadow, that dog in the upper left-hand corner. That was a foster dog that we had named Shadow. And he was about 80 pounds, which is a big dog. And he looked like a black pit bull, but he was primarily actually, oh crap, what are they called? An Australian Shepherd. So his genetics were mostly Australian Shepherd, but the phenotype showed up mostly where he looked like a pitty. And he was 80 pounds. And holy smokes, that was a really bad dog. Oh my God, I loved him so much. But having an Australian Shepherd trapped in a pit bull body that weighs 80 pounds that you can't control, whew, it was very hard times. Okay, Rachel, I think, is giving us a great example. Okay. Example, sponsor won't work steps with someone who utilizes MOUD, or AKA medications for opioid use disorder, stating that they aren't fully clean and cannot share the group either, just sit and listen. So you can come to this mutual aid group, but you can't share because of the kind of medication that you're taking. Or mother wants a child to taper off MOUD because it's trading one drug for another. So the stigma of medications that treat opioid use disorder, because we have a sort of lack of understanding what addiction actually is, there's an understanding that if you have a physical dependence on a medication like buprenorphine or methadone, that then you are addicted to that substance. Actually, addiction has to do with functionality, but we have a deep stigma related to these medications because they treat this, and we have a lack of understanding of what addiction actually is. And so those medications are deeply stigmatized. Hey, you can't share because you're taking this medication, which is, something about that is actually making me feel really emotional in this moment, because sharing in a 12-step meeting is such a powerful moment of being seen and having someone else bear witness to you, which is incredibly healing. And so the idea that you are being muted and you will not have the experience of someone bearing witness to you is just so unbearably painful, and a great example of interpersonal stigma. Okay. Someone, and I love this vulnerability, someone says, to be honest, an example from my own life. I ask my friend about 2 of her kids, but not the 3rd, who is substance involved. That's huge, yeah. So that kiddo doesn't get sort of, or child/adult now, the parent doesn't get to bear witness of their parenting of that child because there's substances involved. Whew. And my guess is that the person doesn't ask this question because it feels awkward, because we associate shame and secrecy with substance use disorders. Remember when Nora Volkow said there's shame and secrecy, so we actually underestimate the burden of substance use disorders? There's so much shame and secrecy, so it feels awkward to ask. And we could ask the question with something like, gosh, I also really want to ask a question about your 3rd kiddo who I care about just as much. And I know there might be some shame here. How are they doing? Tell me what's going on with them. Anything I can do to support. But it feels so awkward because it's shrouded in shame and it's shrouded in secrecy, which, again, good example of interpersonal stigma. Rachel says, personal example, I'm in sustained remission from MOUD, but do not practice full abstinence. Due to my moderated social use of alcohol, I've been told by others that I am not in recovery and was voted off a board of directors of a recovery community organization I was working to launch. Yeah, that's a wild example of stigma. So not fully sober, but in remission from an illness, and presumably not symptomatic, And again, the symptoms are about loss of functionality, but still being told you can't do this thing. Another one from Rachel: family and friends who have died by overdose, both opioids and cocaine, but it was socialized within our families and social groups as a cardiac arrest. Yeah, so people not telling the full narrative because of the shame and secrecy. Okay. All right, so interpersonal stigma. I think we've sort of examined that a bit now. Interpersonal stigma is the stigma that shows up in relationship between two or more people, how a healthcare provider treats a patient, how a family member treats another family member. And of course, interpersonal stigma is born of structural stigma, and it's born of those cultural narratives, right? The way that we treat each other exists inside those larger cultural stories that we tell about what addiction is, who people with substance use disorders are, and how people with substance use disorders get better. And interpersonal stigma and structural stigma, of course, inform self-stigma. So before we get to examples, you guys tell me, what's self-stigma? Michelle says shame, lots of feelings of self-worth and reluctance to seek help associated with one's condition. And that's right, Michelle, self-stigma is shame, and it's when stigma shows up and transforms the narrative that we have about self. And it's so wildly common because these cultural narratives, of course, we will start to embody them. Cultural narratives, for example, of people with substance use disorders don't recover. That becomes a narrative, of course, that we can't recover. So if I'm just an addict and I can't recover, why would I even try? If I'm a POS, if I'm bad, if I'm amoral, why would I try to engage in recovery services, or why would I tend to my health? So self-stigma is those cultural narratives that become embedded as part of our narrative, changes the way that we tell stories about ourselves and changes the way we propel through the world. But it's also the neurobiology of shame. So self-stigma, and as we experience shame, actually changes our neurobiology. And I mentioned this earlier, but I want to highlight it again because it's actually really important. Shame changes our neurobiology, increases stress hormones, specifically cortisol, but others as well. And we know the evidence is very clear that as cortisol levels go up, resiliency for returns to use and desire to engage in substances actually increases. I shouldn't say desire. Substances become more salient. Our ability to invoke prefrontal cortex and not use substances, if that's what we're trying to do, actually diminishes. We're more likely to use more substances the more shameful experiences we have. And that's not sort of just part of the cultural narrative. It's actually the neurobiology of shame. Shame makes us want to use more substances. Shame propels us to use substances as a soothing mechanism when we don't feel good. So self-stigma in many ways becomes one of the most harmful forms of stigma, which again is born of interpersonal stigma and born of structural stigma, becomes self-stigma, which changes our narratives, makes us less likely to engage in recovery services, less likely to tend to ourselves, and makes it physiologically harder to stop using substances. So stigma and self-stigma propel substance use, and bring us back to that very, very first meta-analysis that looked at the way in which stigma impacts people getting into recovery services. Interpersonal stigma increases self-stigma, formed out of structural stigma, and propels us to use more substances and continue in substance dependence, as that initial article called it. So quick recap, because this is one of the primary takeaways. Structural stigma, when it's big, embedded in cultural narratives and institutions and policies, and is about how we fund things and how we write policies for people that are utilizing substances. Interpersonal stigma, the experience in relationship between two people or more that shows up where people experience stigma, which then of course informs self-stigma, which is all about these narratives that we tell about who we are, what we're capable of, what we deserve. and then also changes our neurobiology and makes it more likely for us to utilize substances. And if you got one takeaway from today, I hope it's this. I hope you start to say, oh, I think that's an example of interpersonal stigma, or I think that might be an example of structural stigma, or gosh, I think this is going to show up as self-stigma. So now I'm going to pivot us to some actionable steps. And let's start with language. And I think we are going to have time today to talk about some ways of providing education around substance use that decrease experiences of interpersonal stigma. But let's start with language. I'm basing this slide, or I should say this slide is an image of some pretty high quality research that was done by Robert Ashford and pals. They are out on the East Coast. And I really like to highlight this because Robert Ashford specifically is a person in long-term recovery. And whenever we can highlight the voices of people with lived experience, I try to do it. And you can probably guess why, because it decreases stigma. If we start to tell stories, hey, people with lived experience of substance use disorders have meaningful things to offer, they can recover, etc., then we are changing all of the narratives about stigma. So I highlight this here. This is research done. It's very high quality by people in recovery. And what we're looking at here on the XY axis is whether words increase stigma or decrease stigma or are neutral. So what we're looking at here, x-axis, is location of where the words may or may not be appropriate. And I want to highlight this because I want to be really clear that when we talk about language, I'm going to be talking about the medical setting. As a CareOregon webinar, we're talking to folks that are primarily medical providers, and we're talking the medical setting. I am certainly not going to police someone in a mutual aid meeting saying, hey, my name is Lydia and I'm an alcoholic. Not here to police how people tell their narratives. But in a medical setting, we know that some of these words are actually more shaming and more stigmatizing than others. And it's based on this evidence in which they tell the same story in a multitude of ways, and they change out a couple different key words. And as they change the words, they notice that levels of stigma go up or down or are neutral. So some of these are things that you probably are well aware of. Things like addict or alcoholic, these non-person centered words, we're going to try to avoid those, especially in medical settings. And there's a couple reasons for this in my mind. A, we know they're stigmatizing. The evidence says they're stigmatizing, but also they don't really tell me anything. Medically, saying addict or alcoholic, that doesn't have any medical meaning for me. When you say to me, someone is addicted to methadone, I don't know what that means. Do you mean that they have tissue dependence? Or when someone's an addict and it has to do with methadone, let's say, do you mean that they have tissue dependence on methadone? Or do you mean that they are losing control of their life and they're losing functionality in relationship to the methadone? When someone says that they have if they're a cell phone addict, do you mean that they're losing functionality in their life related to cell phone use? Or do you mean that they use their cell phone a lot? It just doesn't have a lot of medical meaning. So we avoid terms like addict and alcoholic, and of course say things like person with a substance use disorder or person with an alcohol use disorder. That person first language is really key when we're talking about substance use disorders. When we're talking about other things, it may not be key. And the one I always want to highlight here is for autistics. Autistics have said, I don't want to be a person with autism. Autism is a 24/7 experience for me. I'm autistic. Just call me an autistic person, or just call me autistic, right? Autistics have said we don't need person first language, but in substance use disorders, it's very clear, and the evidence is very clear. Person first language, where a person with substance use disorder or a person with alcohol use disorder is the preferred way to talk about it. We absolutely do not talk about people as being substance abusers. And indeed, I would say and highlight that we try to avoid the term substance abuse in all settings. Much like addict or alcoholic, the term abuse doesn't have medical meaning for me. When someone says, I'm abusing my Benadryl, I don't know what that means. Are we talking about loss of functionality? Are we talking about tolerance? And the term abuse is really, really slippery and really, really dangerous. When I say so-and-so is abusive or so-and-so is an abuser, what words come to mind? What images or what people come to mind? And go ahead and put it in the chat. Yeah, Sabrina says physical abuse, like spousal abuse. Someone says intimate partner violence. Absolutely. If I describe, oh, great. Someone who's violent, Paul says. If I describe someone as an abuser, you immediately think of violence. If we weren't talking today about substance use specifically, and I said the term abuser, you would almost immediately think someone who harms pets, someone who harms their partner, someone who harms children. It's about violence. And that's wildly stigmatizing. And it's not to say that substance use disorders don't sometimes make people act in ways where violence is included. I work in an emergency psychiatry room that tends especially to people that have substance use disorders. So I know violence and substance use intimately. And the core definition of substance using does not have to do with violence. People who use substances, it's not a core piece of the definition that has to do with violence. So we want to avoid that term, which can be tricky because we've got things like SAMHSA. We've got other terms where abuse is just built into the name, but especially in a medical setting, like let's say you're charting or you're talking to a peer about a patient or a client. Talking about substance abuse, it's not useful. It's stigmatizing. It doesn't tell me anything. Abuse went away as a medical terminology in the DSM-4. It's not in the DSM-5. It doesn't mean anything to me. And it's wildly stigmatizing and invokes this idea of violence. The next thing you'll see on here that I want to highlight is the term relapse. And you'll see mutual aid meetings, totally appropriate, but if you scroll over to medical settings, it says stop. So oddly enough, and this one sometimes surprises people, the research found that the term relapse invoked negative connotations. It invoked a little bit of shame, it invoked some stigma. And so on the next slide, I will show you guys the sort of preferred way of talking about this. Same with medication-assisted treatment. And this one is much like relapse. It's often surprising for people. Medication-assisted treatment, we shouldn't be saying it per the medical evidence. And this one is surprising. And also, in my mind, it makes a lot of sense. And it makes a lot of sense when we think about the era in which it comes from. And usually I ask for audience participation on this one, but just for the sake of time, and because I think it'll prove useful, I can just tell you real quick. Medication assistance comes from an era of treatment in which there was one true treatment, and that was the 12 steps. 12 steps was treatment. We could use some medications to assist in the very beginning, but the real treatment was this thing. And you'll notice it's medication-assisted treatment. And there's no other place in where we would talk about a chronic illness and a medication associated with it as assisted. So if I were to say, hey, you know, I take lisinopril for my hypertension, nobody would say Lydia takes lisinopril to assist her hypertension treatment, or Paul takes metformin to assist his diabetes treatment. We wouldn't talk about it that way. It's just part of the overall treatment. Those pharmacotherapies are one part of the treatment of chronic illness. Almost all chronic illnesses include medications and lifestyle tending to, and a variety of other modalities to treat a long-term chronic illness. That's how we think about it. So let's look at this next slide, in which I've tried to simplify this for you all. I've tried to make something that if you want, you can like print out, and it simplifies and pulls out some of the more salient pieces here. So avoid saying things like substance abuse or substance abuser, just talk about substance use. You can even, like, if you need to sort of qualify it, you can talk about risky substance use, and then talk about what the risk is. Don't just assume all substance use is risky. Sometimes people use substances and it's not risky at all. If there is a risk associated, talk about what it is. Medication-assisted treatment, we touched on this one. We want to avoid this idea that it's assistance for the real treatment. And so MAT exists all over the place. The acronym MAT, it exists in all kinds of different places, laws, policies, funding streams, it exists all over the place. And so ASAM in 2019 They put out a little sort of white document in 2019 where they changed the definition of addiction, which I love to talk about, although it's not in scope for today. They changed the definition of addiction. And then they also update and say, hey, there's a couple terms that are stigmatizing. Here's what we would like to do to replace, or here's how we'd like to replace them. And one of the things they say is medication-assisted treatment. Turns out it's stigmatizing. We're going to replace this for medication for addiction treatment. That way, MAT still works, but it's a far less sort of reductive way of talking about the medications. So just medication for addiction treatment. Boom, it's perfect. It's much like saying antidepressants, right? Here's a medication, it treats depression. Here's a medication, it treats addiction. Still MAT, totally works, medication for addiction treatment. We're going to try to avoid the term relapse, and the replacement here is recurrence of use or return to use. But relapse, per the evidence, stigmatizing, so we're going to describe that someone is using again in a different way. Again, return to use, recurrence of use, any of those are appropriate. And then I put clean and dirty on here because these are a personal pet peeve. I actually don't know of any studies that look at how stigmatizing they are, but any opinion piece, any review article that talks about destigmatizing language in the substance use disorder setting is going to talk about clean and dirty. Much like so many other things we've chatted about, they don't tell me anything medically. When you say a urine drug screen is dirty, I don't actually know what that means. It's also wildly dehumanizing. Clean or dirty? This human is clean, this human is dirty. Let's just talk about what the person is using. They are currently using fentanyl, or what is positive or present in a urine drug screen. And this one is so tricky for people to get away to. Urine drug screen was clean. Okay, I would like to know then, do you mean urine drug screen didn't have anything in it except for prescribed medications? Those are the ways that we should be talking about this. What's actually present in a urine drug screen, or what is someone actually using? So I would just say, be specific and accurate. There's nothing we can do that like rapidly replaces clean and dirty, but be medically accurate when you talk about this and be specific in terms of what you're talking about. What substances? It's really important, actually. And I've got a couple notes on language. Again, I made this for you guys to just try to simplify it. And if you wanted something to print out or hang on the wall, this can be useful. But there's sort of a couple notes here. And it's just thinking strategically about how to make change. And it's really based in the tenets of motivational interviewing, which is that when we're trying to make changes in terms of language, it's really about how we talk. So these destigmatizing word suggestions I offer, they are not something where we're going to go around policing someone else's language. Very specifically, we're not going to police patients or clients or peers in terms of how they talk about their experience. Someone's not going to come in for an office visit with me on Monday and said, Doc Lydia, I relapsed on Saturday. And I'm going to go, you know, actually, technically, we call it return to use. That would be the most horrifying and dehumanizing experience. I'm not going to correct someone. I'm not going to police how someone talks about their experience in the world and how they identify. Absolutely unnecessary. The language change is for myself. And I even would expand the non-policing to my coworkers. I don't tend to go around and tell people how to talk. When someone misses the content of your message and focuses on specific words, it often can feel incredibly shaming and bad. The thing that you wanted to convey has been lost so that someone can correct something. It doesn't feel good. So what I do is I just model. I hang up posters. I'm probably like the annoying poster lady at every job I've ever had. In fact, if you've ever worked with me, you probably have known me to hang up posters of how we can talk about people with substance use disorders, because it's such a quick, actionable way to destigmatize things. But you very rarely ever see me correcting people in the moment. So I connect, I don't correct, and then I model. Here's how we do this. All right, and I want to give you guys one more takeaway, and then we can pivot over to Q&A. We talked a lot today about patient experiences in the healthcare setting, and the way that those experiences can either propel engagement or repel people from engagement. And so I want to offer something very, very specific, and you may want to write this down. It's very specific, it's very actionable, and it's one of those tricky, slippery places where we may not be stigmatizing, we may not be shaming clients, but if we don't overcorrect and over sort of do it in terms of being client-centered and trauma-informed, people can easily come away with experiences of being stigmatized. This comes directly from motivational interviewing, and it's called elicit, provide, elicit. Some people also talk about this in motivational interviewing as ask, tell, ask. But when you look into the data around this, or if you wanted to like Google it or watch videos, in general, motivational interviewing calls this elicit, provide, elicit. And again, to recap, this is something where even if you're not stigmatizing and you're not trying to shame someone and you're doing things mostly right, if you provide patient education ever so slightly in a way that feels like it's paternalistic, patients are going to be propelled away from care. And this is a tool to engage patients in care where we promote conversation versus direction, and we really actively avoid paternalizing and anything that could feel stigmatizing or judgmental. It gives us a tool for providing education in a way that's incredibly trauma-informed and destigmatizing. So the first elicit is where you elicit a micro consent to provide the education. And when I say you elicit a micro consent, what I mean is you want to understand if it's okay for you to get into the education. Sometimes patients don't want to be educated about stuff. Sometimes they know. I'll never forget one of the first times I went into a withdrawal management center here in town, and on the wall was these big posters that pointed to just a couple places on the body that, no, not a couple, many places on the body that IV drug use harms. And it was meant to be educational. But it's not like anybody going into that withdrawal management center that used drugs IV doesn't know about the harms of IV drug use. So that poster becomes shaming instead of inviting. People know, often they know things already. And so if we start telling people things about their lived experience, especially, it feels shaming and it feels paternalistic. So the first thing you're going to do is, hey, is it okay if I talk to you about this? And in that, you also want to see if you can garner a little bit of their previous knowledge base. So you might say something like, hey, has anyone ever talked to you about the risks associated with IV drug use before? And would it be okay if I tell you some of the things that I know about the risks of IV drug use? And I'm just using IV drug use as an example because we talked about the poster. This could be anything. Hey, would it be okay if I talk to you about, using Narcan in the community? Hey, would it be okay if I talk about what happens when we drink alcohol every day? So the idea is you're going to get a buy-in. Hey, is it okay if I talk to you about this? And you're also going to see if you can understand what someone knows about this subject already. When it comes to substance use, our clients often know far more than we think they do because, hey, turns out knowing all the things about something is not always what it makes it actionable. How many of us said that we don't floss as often as we know we should? We all know we should floss. Does that make it actionable all the time? No, not at all. So just because patients know things doesn't mean it's actionable. So we're going to make sure that we understand what they know so we don't start telling them things we already know. My favorite story about this is the time that I went out to eat with, years ago when I was with my partner, before we had a kiddo, we went out to eat with one of my partner's friends. And the friend was like really, really into CrossFit. And so he just started telling me like all about CrossFit. You could tell he was really excited about it. He started telling me all about CrossFit and all about what CrossFit did to levels of cortisol and serotonin. And he started telling me how serotonin was just like so bad for me because it made me inflamed and it like did all these things to my endocrine system. and how cortisol was like really good and made you feel more connected to people and like gave you better self-esteem and like kind of like more energy throughout the day. And it was such a bonkers conversation because I hope that you picked up on the fact that he got cortisol and serotonin switched. He was telling me how good cortisol was when actually cortisol is totally neutral, but if you have too much of it, it's bad. And how bad serotonin was. And actually, like, serotonin is kind of stuff that we kind of like, and a lot of people try to modify their diets and do specific exercise to try to get more serotonin in their systems. So he was completely wrong, and he hadn't checked in to see what I do for a living, which at that time was mostly teach people about the neurobiology of trauma, which is directly related to the pathophysiology of cortisol and serotonin. So he gave me this big spiel about cortisol and serotonin and all this stuff, but I knew it far better than him. And so it became in some ways really embarrassing for him. I don't think any of you would embarrass yourselves with that kind of thing, talking to a patient about substance use. But the idea here is you got to know what someone knows before you start explaining things to them. And you want them to let you know it's okay. So you're going to elicit a micro consent, garner previous knowledge base, and then you can provide the knowledge. You know what, this should have said provide education. I added this slide last night. Provide education that honors previous knowledge. So then you can do some education. Hey, what we know about Narcan is you can use it in the community when this. You don't even have to be utilizing substances for Narcan to be useful for you to carry. Here's why. So then you provide the education. And then the second elicit is to elicit integration. And this piece is less about stigma, but it's part of the traditional elicit, provide, elicit. It's to make sure that the patient understands what you just said. How often have you all been told something by a medical provider only to leave the office and not really understand how that would pertain to your life or how you might make it work in your life? How many of you left an office visit or got a patient handout with a ton of education that meant nothing to you? It has happened to me so many times in my life. So this third elicit is to make sure that the knowledge or the education that you are sharing can be integrated. So you might say something like, what do you think that means for you? Oh, this reminds me, I forgot something very important under number 2. In number 2, you're going to provide it as neutrally as possible, never using the words I and you. You might say something like, the evidence says, or what we think we know about X is Y. Never, I think you should, or you should do X, Y, Z. The idea here is that it's completely judgment-free. It is neutral knowledge being exchanged between 2 humans. And then 3 says, what do you think this might mean for you? Does that sound like it has anything does it have anything meaningful for your life? Does that sound like it's useful information for you? Anything that's sort of a brief, chatty way of saying, great, now reflect on that as you integrate the information for yourself. So this is a way to provide education that's not paternalistic, very humanizing, very trauma-informed, and is going to engage people in your care as an equal and increase conversation versus medical provider direction. And it's not, if you didn't get anything from this today, no big deal. It's not central to this. I just wanted to give you guys more actionable takeaways for how to make visits feel less and less stigmatized and more engaging. All right, so that's most of what I've got for today. I want to just do a very, very quick recap. First, I want you guys to know that I'm always available to you for questions. Here's my Gmail address. You can always contact me with the questions. We're going to pivot to questions in a second. And before we pivot to formal Q&A, I want to do just a quick recap of where we've been today. Sometimes I think this talk can seem like we're bouncing around a lot, but the idea is that I want it to move from things that are very clear and like living in your life, like what you see on TV, to how that then is reflected in the medical evidence. Because if I just share a bunch of medical evidence, And we just like, it actually, what I've tried to do in some ways is elicit, provide, elicit, but in an educational experience. So engaging you in what you see as those cultural norms, I think we did that. Here's how things show up in media that have really influenced the way we think about things. Those media narratives have really, really influenced the cultural stories that we have. And they also tell us much about what the cultural stories are. Things like addiction is really hard to recover from, and most people don't recover. Those kinds of things are those cultural stories you see both alive and then also reflected back to us because of media. And then we have sort of interjected and laid side by side how that shows up with what the medical evidence is. And then we talked a little bit about sort of actionable takeaways, language that decreases stigma and increases, then we think, engagement in recovery services. And now, on that note, we can pivot to Q&A.